Hi everyone. So in this video we will be studying second part of surgery images. The first image shown here is of lower urinary tract symptoms in men. In the lower urinary tract symptoms, also known as LUTS, we have voiding symptoms, storage symptoms and complex symptoms. In the voiding symptoms or obstructive symptoms, we have hesitancy, poor stream, intermittent flow, incomplete emptying with associated frequency, post void dribbling, and overflow incontinence. In the storage symptoms, we have frequency, nocturia, urgency, and urgency incontinence. And in the complex symptoms, we have hematuria, recurrent UTI, acute or chronic urinary retention, and urinary incontinence. So these are all the LUTS which we have. In the option we can be given three right answers and one wrong answer, and we have to choose the one which is not LUTS. So we need to go through the list to answer these type of questions. Then next we have the indications for the CT, whether the CT should be done within 1 hour or within the 8 hours. In the indications marked with the red, we have to do CT within 1 hour. If the GCS is less than 13 on initial assessment, less than 15 at 2 hours after the injury on assessment in emergency room, then is suspected open or depressed skull fracture, any sign of basal skull fracture, post traumatic seizure, focal neurological deficit, and more than one episode of vomiting since the head injury. Then, the mark with the blue ones are those in which the CT should be done within 8 hours. That is, age more than 65, history of bleeding or clotting disorder, and dangerous mechanism of injury like a pedestrian or cyclist struck by a motor vehicle, an occupant ejected from motor vehicle, or a fall from height of more than 1 meter or 5 stairs, and more than 30 minutes retrograde amnesia of events immediately before the head injury. So these four, that is age, bleeding disorder, and dangerous mechanism, and retrograde amnesia. These are the indication for CT within 8 hours of the head injury. Then in next slide, we have the image of the gastric volvulus. In the gastric volvulus, there will be a circular mass present behind the cardiac shadow and in the thorax. And the history will be of abdominal pain and vomiting. Okay, the next image is of pneumoperitoneum. Air under the right diaphragm is shown. Air under the left diaphragm is due to stomach, but air under the right diaphragm is due to pneumoperitoneum. Due to air in the peritoneal cavity, it is present in cases of the perforation. This image we have also discussed in the radiology section. Then next image, we have the four images. The patient suffered from blunt trauma to the chest and abdomen. In which of the following further investigation is required before inserting the chest tube? The first image we have is of the diaphragmatic hernia. Okay. The next image we have of the tension pneumothorax. This black is due to the air, and the air is pushing this cavity, pleural cavity contents towards this other side. So it is case of tension pneumothorax. Then this is case of flail chest in which the ribs have been fractured, and this is the case of pneumothorax in which there is opacity due to the accumulation of the blood in the pleural cavity. So, in which case we will do the further investigation in the diaphragmatic hernia. In the tension pneumothorax, flail chest, and hemothorax, we can straight away put the chest tube. But in diaphragmatic hernia, the chest tube is not put straight away. We require further investigations. The next image we have is a child presenting with abdominal discomfort and intermittent abdominal pain, and the radiograph is given below. What is the most likely diagnosis? So this is again the case of diaphragmatic hernia. The contents are herniating from the abdominal cavity to the pleural cavity. So it is a case of diaphragmatic hernia, and it is on the left side. Heart is on the left side and hernia is also on the left side, and it is on the posterior side. So left posterior is the Bogdalek hernia. On the left side and posterior is the Bogdalek hernia. While this similar history, but the mass is on the abnormality is on the right side, and the anterior. Then it is the Morgagni hernia. How will you remember? Remember RAM, Ram. Our right anterior is Morgagni, and the other one which is left is Bogdalek. The next image we have is of the aortic dissection. Aortic dissection. See, this is the aorta, and the aortic dissection means separation of the wall has occurred. It is a CT image, and the contrast is put into the vessel. So one section of the aorta is showing the contrast and other is not showing the contrast. It is classical image of aortic dissection. The next we have the image of the Gynococcus granulosus cyst or the hydrated cyst. Hydrated cyst histopathological image. See, it is the hydrated cyst wall consists of acellular lamellar deposit and is lined by thin germinal layer which brood capsules form. It has two layers, the germinal epithelium and the other one is the germinal epithelium is the endocyst, and then this is the ectocyst. Two walls and the pericyst. The third wall is formed from the surrounding tissues. So there are basically three walls. The pericyst is from the surrounding tissue, while two are this is the own wall. The next CT image we have is of extradural hemorrhage. Extradural hemorrhage, classical biconvex shape, and it does not cross the midline. Okay, it will not cross the midline, it can cross the suture line. Extradural hemorrhage means outside the dura. Then we have the histopathology of Barrett's esophagus showing intestinalized with epithelium with goblet cell as opposed to normal stratified squamous epithelium. See, this is the stratified squamous epithelium in the esophagus. Then this is the intestinalized epithelium, means goblet cells are present. Then this is the stomach, pseudo stratified columnar epithelium. Okay, between the esophagus and the stomach, in the lower esophagus, we have the intestine type epithelium, then it is known as Barrett's esophagus. The next image we have is of Peutz-Jeghers polyp. Peutz-Jeghers polyp is type of hamartomatous polyp, and the classical features of it is arborization. Arborization means tree-like pattern, branching pattern, and the pseudo-invasion. And the chromosome linked here, it is not mentioned here properly, it is chromosome 19. And the gene is STK11 or LKB1. STK11 or LKB1. And it is autosomal dominant mutation. Then next we have the image of Crohn's disease, histopathological image. There is a mucosal ulcer. Mucosal ulcer will be there, and then there will be transmural, means throughout the wall we will be having inflammation in the muscular layer as well as in the mucosa and submucosa. And the epithelioid granulomas with giant cells are present in all the layers of the vowel. Crohn's disease. Then next we have the types of breast cancer on the hormonal status basis. We have luminal A. Luminal A is ER and PR positive, estrogen and progesterone receptor positive, and HER2 negative. Then is luminal B. B is all the three are positive. Okay, B positive means all the three ER, PR as well as HER2 new is positive. And then what are the drugs used in luminal B? First line is trastuzumab or Herceptin. Second is second line is lepanib, and third line is sunitinib. Then we have the basal cell type. In the basal cell type, we have all the three negatives. Okay, then is HER2 new. In the HER2 new positive, we will have ERPR is negative, but HER2 new is positive. Okay, then this is the histopathological image. In the histopathological image, the different dyes are used, and we are testing for the status whether the which receptor is positive. Okay, so this one is ER/PR positive. First one is ER/PR positive and HER2 negative. ER is brownish color positive, PR is brownish color positive, but HER2 is negative. Then next one is, here the brown color is present in all the three. So it is all positive, luminal B type. Then this is only HER2 positive. And this is all negative, means basal side. Luminal A, luminal B, HER2 positive and basal cell type. This is how the histopathologically it will look. Next image we have is of chital split. Chital split on the anti-mesenteric aspect of the ileum to accommodate the discrepancy in size. See, we have resected a part from the bowel and the above part is narrow and the next part is more in size, more diameter in size. So how we will accommodate this discrepancy in size? We will accommodate it with the help of chital split and it is given on the anti-mesenteric aspect. Okay. Next image we have is of chemoport. The X-ray image of the chemoport. Then this is another image of the chemoport. It is basically used in persons undergoing chemotherapy. We can't put means cannula every day. We have to give drugs for the long duration. So we can't just keep putting peripheral cannulas again here and there in the patient. So we use the instrument called chemoport for the continuous means for the long duration of medications. This is Hassan trocar pneumoperitoneum. It is the instrument used for creating pneumoperitoneum in the abdominal surgeries. It is basically used in the cases where there are adhesions in the surrounding intestine. Okay, Hassan trocar. And this image is of Verey's needle. When the Verey's needle is also used in creating pneumoperitoneum. These two instruments are both are used in creating pneumoperitoneum. Then next we have the image of SEEP classification. SEEP classification is used in case of varicose veins. In the SEEP classification, we have C for clinical, E for etiological, A for anatomy, and P for pathophysiology. In the clinical, C0 is no clinical sign. C1 is small veins, that is telangiectasia reticular veins. C2 is varicose veins. C3 is edema. In the C3, edema occurs and in the C4 other skin changes. C4 is further divided into C4A pigmentation, C4B lipodermatosclerosis and C4C corona phlebectasia. Then in the C5 there is ulcer with the healed ulceration. Skin changes with the healed ulceration. And C6 is active ulcer. Okay. Then is etiology. In the etiology we have the congenital, primary, secondary. Secondary usually due to prior DVT. And in the anatomy we have the superficial veins, deep veins and perforating veins. In the pathophysiology we have reflux and obstruction. So we need to remember basically important is the C classification. What all changes are seen in C1, 2, 3, 4 and 5 and 6. Then next is regarding the trophic ulcer or decubitus ulcer. These is grade according to the condition. Grade 1 is non-blanchable erythema, just erythema. Grade 2 is partial thickness skin loss. Partial thickness of skin is lost. Then grade 3 is full thickness skin loss. Full thickness skin loss is there but it is not extending below the fascia. Okay. But in the grade 4, full thickness tissue loss. Here the tissue word is there. Okay. So it has extend beyond the fascia and the bone may be visible. See, bone is visible in this. Okay, then there can be suspected deep tissue injury where the epidermis is intact but there is bluish or purplish discoloration, and there can be ungradable. Ungradable is the case where the necrotic material or slough is present over the base. Okay. Next image we have is of pneumatic compression stocking. Pneumatic compression stocking is basically given in the case of varicose veins. This image is of Romovac drain. Romovac drain is a type of closed suction drain. This is image of Humby skin graft. Humby skin graft knife. It is used for taking the skin graft. Then next image is of high flow nasal cannula. High flow nasal cannula. This is another image of the chemoport. Chemoport we have seen before also images, and this is another image. Then this image is of monopolar cautery. Monopolar cautery is used in cutting and coagulation of tissues in the surgery. So this was basically the second part of the surgery images. Few images are left. We will be discussing it in the third part. I hope you will find the content useful, and please like and subscribe my channel. Thank you.